Good afternoon, everybody. My name is Marcus Green. I'm Chief Executive of Action on Pre-eclampsia, and I'd like to warmly welcome you to this session today, which is what women's health in pregnancy can tell us about their future cardiovascular health. Excuse me, it's a talk that's going to be given by Professor Abigail Fraser. Come back to Abby in a moment, but first of all, Action on Pre-eclampsia are delighted to be involved in the POPPY study. This is one of the really important pieces of work that's taking place in the country at the moment, and we're very pleased to be involved. What we're going to be looking at over the next hour is exploring women's health in pregnancy, what that can tell us about future risk of cardiovascular disease. And Abby's going to present some of the latest research and findings linking common complications such as preeclampsia to later life risk of heart disease and stroke. And we're going to talk about these links, what we know, what might explain them, what knowledge gaps remain. So our speaker today is Abby Fraser. Abby is Professor of Epidemiology at the University of Bristol, where her work investigates the links between women's reproductive health and chronic disease in later life, particularly health in pregnancy and long-term cardiovascular health. So just the right person for today. Professor Fraser is a POPPY investigator, and the study is recruiting women prior to pregnancy. We'll follow them through pregnancy and beyond to compare measures of cardiovascular health, such as blood pressure, in women who develop pregnancy complications. So, without any further ado, I will hand over to Abby. Thank you very much.
Thanks, Marcus. Thanks for that introduction, and hi, everyone. It's really nice to see you, and thanks for giving up some of your precious time this afternoon to listen to this talk. So I know that Zoom just because it's Zoom is very difficult for kind of interactions. But if at any point I've said something that's unclear and you want to ask a question, please do put up your hand or stick something in the chat. And my colleague Ava here is going to monitor the chat and will alert me to any questions I might miss because I'm busy talking. So please do feel free to interrupt. Let's get going. I really love this quote from John Good, who already in the 19th century recognized that women's reproductive health and how that is going really tells us something else about how a woman's health is more holistically, more generally. And since that quote, we now have quite a substantial evidence base that really suggests that that is the case. And the figure that I've kind of put up here is from the American Heart Association, which has really embraced this idea that women's reproductive health does tell us about a woman's risk of heart disease and stroke in later life. And it's something that I've been interested in. As Marcus said, that's been a big part of my research life. And particularly, and this is why we're here today, I want to talk about the links between adverse pregnancy outcomes and that term. You know, different people use different terms. We talk about adverse pregnancy outcomes. We might talk about pregnancy complications or even placental syndromes. They all kind of mean the same thing. Mainly, we're looking at the hypertensive disorders of pregnancy, so preeclampsia and gestational hypertension. The difference between them in terms of diagnosis is that preeclampsia is hypertension that first diagnosed in pregnancy alongside protein in the pregnant woman's urine, whilst gestational hypertension is without any protein in the urine. We're also talking about, under that umbrella term of adverse pregnancy outcomes, we're talking about preterm delivery, so delivering before week 37 completed, 37 completed weeks of pregnancy, and of delivering a small baby, so a baby that potentially hasn't grown to its full potential in utero. And let me just, my slides, yeah. So this is basically summarizing what I've said so far. And really the reason that I have kind of put a line through gestational diabetes is gestational diabetes is an adverse pregnancy outcome or a pregnancy complication, it's slightly different to the other adverse pregnancy outcomes just because of the type of condition that it is. And so I will not be talking so much about gestational diabetes, although we know that gestational diabetes is it's an important and a leading risk factor for developing type 2 diabetes postnatally, which in itself is a leading risk factor for heart disease and stroke in later life. So this slide really is just summarizing a lot of the studies, and we've kind of haven't had an explosion of these over, I would say, the last decade or so, showing what is now really accepted as a robust link between experiencing an adverse pregnancy outcome during pregnancy. And on the left column there, you can see that kind of list. So it's gestational hypertension, moderate and severe preeclampsia, preterm birth and stillbirth. So that's on the left column. And that column that I've put a red box around is the pooled odds ratios. And what the pooled odds ratio is basically how much increased risk do we see in women with those conditions versus those who don't have the conditions. So you can see say just at the top that we have a 1.67, which means that women with gestational hypertension have a 67% increased risk of having cardiovascular disease in later life versus women who have had only uncomplicated pregnancies or have not had gestational hypertension in their pregnancy. And you can see that all of those numbers, and it's pooled because this is a summary of multiple studies. So this table has kind of taken all the evidence and given us these estimates that average across multiple studies that have actually, and the number of studies are in that column just before that one with the red box around them. And so we see that more or less, to kind of summarize, these pregnancy complications or adverse pregnancy outcomes are associated more or less with a doubling of risk of heart disease and stroke in later life in women who have experienced these pregnancy complications. I do want to emphasize, because some of you might have these experiences, might have had a pregnancy that was affected by preeclampsia or by preterm delivery, that this is the population average. So this is taking, across the population and looking at the average risk in women with and in women without adverse pregnancy outcomes. So this is more or less what I've already said. Another point here that I think is worth mentioning is that this risk of cardiovascular disease does increase. So we've observed kind of what's called a dose-response relationship. So women who have had more than one pregnancy affected by an adverse pregnancy outcome, their risk goes up compared to a woman with only one pregnancy affected by adverse pregnancy outcomes. And as I said, this link between adverse pregnancy outcomes, these complications, and future cardiovascular disease is really robust and is already made it into clinical guidelines. So it's recognized as a meaningful risk factor. And I'll come back to what that means really and how we can use that later on in the talk. And so what I was interested in, you kind of think, okay, so we know there's an established link between adverse pregnancy outcomes and cardiovascular disease, but there is a really important term in epidemiology, so looking at populations and kind of running statistics and statistical tests on these big data sets. What we're interested in is, are these adverse pregnancy outcomes, or a question that I was interested in asking, and I know that Ava and Carmel and part of the POPPY study, this is what we're trying to do, and I'll talk a bit about that as well. Are these adverse pregnancy outcomes causing the later life cardiovascular disease? So is it that a woman develops, for example, preeclampsia, and there's a hypothesis that potentially the preeclampsia, the high blood pressure, damages the kidneys, damages the vasculature, so our arteries, damages the heart somehow because it increases the load on the heart? Is it that's happening? Or is it that actually that adverse pregnancy outcome is simply identifying women who already had some sort of inclination or propensity, or for some reason are more likely to have cardiovascular disease, and then they get pregnant, and that load of pregnancy, or that challenge of pregnancy, of supporting a growing fetus, just becomes too much, and they develop these adverse pregnancy outcomes. But actually, it's all caused by something else, and you can see that box with that's denoted C with the kind of a box around it, and that's for confounding. So is there a third factor, for example, genetics or adiposity, that kind of predisposes women, is the reason why they might develop the adverse pregnancy outcome and also cardiovascular disease in later life, but the adverse pregnancy outcomes aren't actually causing the cardiovascular disease in later life? And that is both, to me, intellectually just interesting, and an interesting area to research, but it also has practical implications about where we should be intervening. Is it during pregnancy? Is it before pregnancy? And I'll talk a tiny bit more about that again later on. And kind of a different way of thinking about this is those kind of figures that you have at the bottom of the screen. So if we think that, the red line is women with adverse pregnancy outcomes. The blue line, and I hope you can see the colors okay. The blue line is thanks for nodding. The blue line is women who do not develop pregnancy outcomes. And the x-axis, so at the bottom, it's basically age or time. And those blips that you see that's where that yellow sign saying pregnancy is. That's what happens during pregnancy, generally, to what we've termed here on the y-axis cardiometabolic function or dysfunction, or we could call it cardiovascular health more generally. It really doesn't matter which term we use. And so in the first scenario, you can see that the red line is higher. So women have more adverse cardiometabolic or cardiovascular health even before they become pregnant. For all women, this dysfunction increases during pregnancy, and that is totally normal. That's what happens because growing another person inside you puts a load on your body. But those women and you can see that those curves are parallel to each other. So the red women, those with the adverse pregnancy outcomes, already have more adverse levels, worse cardiovascular health before pregnancy. But the curves track, they're completely parallel. So we're not seeing a specific effect of the adverse pregnancy outcome. And this is in contrast to scenario B that you can see, where everybody starts in the same place. So they all have the same cardiometabolic or cardiovascular dysfunction level or function or health, whatever we want to call it. Then during pregnancy, the women in the red line, so those with adverse pregnancy outcomes, their dysfunction increases more, which is, we know, happens more than women without adverse pregnancy outcomes. But then you can see, and it's a bit subtle, but you can see that the curves diverge. So the cardiometabolic dysfunction in the women with the red is greater after pregnancy, and it kind of, it goes up quicker than the women in the blue line without the adverse pregnancy outcome. So this is what we would expect to see if it was the adverse pregnancy outcome causing the cardiovascular disease risk in later life. While scenario one is saying, no, actually, it doesn't cause anything. It just detects those women who had worse cardiovascular health even before they got pregnant. And scenario three is a slight curveball because it adds another element, and that is us thinking about what does a healthy pregnancy do to women's cardiovascular health. And I'll talk a bit about that as well because we have some data there. And it might be that a normal pregnancy is good for you, maybe it's bad for you, what's going on there. And that's that dashed green line that we've added in scenario three. So this is work that we have been doing to answer this question over the last 10 years or so. And this particular slide that I'll talk you through, these figures that are not so nice because they're not in color, but are actually based on, so whilst those figures were a cartoon that we drew, this is actually data, so real world data, and it's based on data from Norway, from some studies called the Hunt studies, where in a certain region in Norway, every adult over the age of 20 is eligible to come for a screening test for cardiovascular disease. And it's also a research study. So they agree to participate for their data to be used in research. And so these checks for cardiovascular health happen every 5 years or so, which creates this amazing data set where we actually have repeat measures of different cardiovascular risk factors in women over time from before to after they have had a pregnancy. And so the pregnancy in these figures are where both of those, both the dashed and the dark line break, because we didn't use data during pregnancy because so I'm sure you probably know blood pressure changes a lot during pregnancy. Obviously, weight changes a lot. That kind of you don't really even need to say, but things go very different. You can't compare what happens in pregnancy to what happens outside of pregnancy. So we didn't want to use data from pregnancy, but we've used the data from before to after pregnancy in these women. And as you can see, the top two panels, A and B, are systolic and diastolic blood pressure, and the bottom two are body mass index, which is the way that we kind of measure adiposity and correct for height and waist circumference in these women. And what you can see is, first of all, that for everybody, these things go up as women age. From the age of 20, our blood pressure goes up, our BMI goes up, our waist circumference goes up. That's how it is. So that happens for everyone. But then the two curves are one, the dashed line with that and the width of the gray area around it is kind of, it says how confident we are in that estimate. So they're a smaller group, so we're less confident, and that's why that gray area is a bit wider than the very dark curve where that gray area is really, really small, because there are lots of women who have had healthy pregnancies that were uncomplicated by these adverse pregnancy outcomes. And what you can see, if you think back to the cartoon, they very much look like scenario A. So we're seeing before pregnancy, that little bit in their 20s, that women who go on to develop an adverse pregnancy outcome, so those in the dashed light gray line, have higher blood pressure and higher body mass index and weight circumference from before pregnancy. And the curves, although, they're a bit messy because real life is messy, it's not a cartoon, but I would say that they are kind of more parallel than divergent. So this is suggesting that adverse pregnancy outcomes doesn't have a big causal effect on these cardiovascular risk factors measured repeatedly across the life course in these Norwegian women. And so The other thing that I thought was worth sharing here is that we did the same, excuse me, we did the same looking at just pregnancy. So parity is the number of children a woman has. And here we have looked at those women with children and multiple children, hence those, several breaks in that dark curve here. So here, those are the women with pregnancies, regardless of whether they were complicated or not. And the dashed curve is women who didn't have any pregnancies during this time. And what you can see is that the women who did have pregnancy had a lower systolic and a lower so had the same, blood pressure prior to their pregnancy as women who didn't have pregnancies. So that left side of the figures in age 20, 23, kind of that bit. So they start off the same, but interestingly, blood pressure drops after each pregnancy. And you can see that from that the dark curve, that it kind of falls after the first cut. So that's first pregnancy. It falls a bit more, but less after a second pregnancy, and the same after a third pregnancy. And then what happens is that blood pressure increases as women age, but it takes a really long time for the blood pressure in women who did have pregnancies to catch up, and they don't completely catch up with the blood pressure in women who don't have pregnancies. So I think there are two things that we can learn from this. A is why do women, so you might ask and wonder, why do women who have pregnancies have lower, slightly maybe lower blood pressure to begin with? And we know that there are conditions that are causes of infertility, such as polycystic ovary syndrome, that are characterized by more adverse cardiovascular health as well. So it might be that something that has to do with their cardiovascular health is also a reason for them not having children. Although there are many reasons why women don't have children, they might choose to not have children as well. But that might be kind of explain some of it. But I also think that this is really nicely showing that actually a healthy pregnancy is, and I find that quite interesting, is protective of your blood pressure. So it lowers it, and it actually doesn't come back up for many, many, many years. It kind of tracks underneath that curve for the women who don't have children. So yes, so having a pregnancy in general is protective for at least for blood pressure. And so all of that work was done in the Hunt studies, but we wanted to know, do we see the same in the UK? And so this is work that I have been doing more recently in a data set that is called CPRD, which is basically a dump of all of the routine primary care interactions in a subsample, a representative subsample of GP practices in the UK. And here we've done exactly the same. So the same kind of, curves that I've talked through in detail in the Hunt study, we've replicated that analysis in this big data set in the UK, so the CPRD. And the figures that I'm showing you here, just as an example, are those for women with normal blood pressure. So that's the solid line. And then the big dashes is for women with gestational hypertension. And then the very small dashed line is for women with preeclampsia. And you can see that for the women with hypertensive disorders of pregnancy, so both preeclampsia and gestational hypertension, again, that they tend to be the levels of systolic blood pressure, that's SBP, DBP, diastolic blood pressure, BMI, cholesterol, glucose, they're higher already from before pregnancy all the way through to after pregnancy. And here that x-axis isn't actually age, it's 0 is the pregnancy, and then kind of -10 is 10 years before pregnancy, and +10 is 10 years after pregnancy. But the curves look very similar if we change the axis and make it age, which it was like in the Hunt study. So there's no real difference there. So we feel like a lot of the population studies and the data that we can look at from these big data sets are pointing in kind of hinting that adverse pregnancy outcomes may not have a causal effect. So they may not cause that damage. And this is a population average, and that's really important to remember. More generally, it's leaning towards the adverse pregnancy outcomes, identify women who have more adverse cardiovascular health before pregnancy, rather than saying adverse pregnancy outcomes do something to women's bodies that then makes them have a greater risk of having heart disease or a stroke in later life. But there are also really important caveats here. And that is that we're only measuring really crude kind of cardiovascular measures. And this is routine data. So there might be reasons why some women have more measures of these routinely and others have fewer measures of these. And they're they're spaced around pregnancy here, there, and everywhere. And so it's a really good hint, but Marcus mentioned the Poppy study, and that's what we're trying to do now. And Ava and Carmel, my colleagues on the call, are instrumental and really, yeah, we're all involved in this really exciting study that I wanted to share with you, which I have no results for because we are only recruiting women now. But what we want to do is overcome those caveats from using, available data that's out there and actually look at this kind of properly and rigorously and measure lots of different aspects of cardiovascular health so that we can come to a kind of definitive. I'm always scared of saying definitive because, every study has its weaknesses and, you know, things come up and you think, oh, I'm going to have a final answer. And actually, there's always more to be done. But really, what we're striving here to do is follow up women from before they're pregnant till a year after, and look at how their cardiovascular measures change over that course, that chapter of their lives in women who have had an adverse pregnancy outcome and in those who don't. And it's really challenging because recruiting women before they are pregnant, not all of them will get pregnant. And certainly, thankfully, not all of them will develop preeclampsia or preterm or whatever. So it means we have to start with really, really big numbers to kind of then come down to have those enough women who have developed an adverse pregnancy outcome for it to be meaningful and for us to really be able to kind of with any certainty say it's all about pre-pregnancy. It's not about the adverse pregnancy outcome, or maybe it's a combination of both. In some women, maybe it doesn't do any harm long term, the adverse pregnancy outcome. Maybe in some it does. We'll have to see what the Poppy shows us. And I just wanted to share a few images from the media attention that this study has gained, because it really is really, really exciting. And hopefully we can, invite you to talk when we actually have the results and share those with you. So I'm really conscious of time. I'm going to whiz through a few more slides. And Marcus, please do tell me when you want me to stop talking. I
Keep
wanted
going.
to, okay, I will, because I love this stuff and it's lovely to talk to people who are interested. But one of the other questions, so that was a kind of causation. What's causing that increased risk of cardiovascular disease? But I alluded to it a bit at the beginning of the talk. Another thing is, can we use this link that we know exists, that we absolutely know that exists between adverse pregnancy outcomes and later life cardiovascular disease to calculate or better calculate a woman's risk and therefore tailor treatments and interventions to prevent that risk or to mitigate it or to lower it if we know something about her obstetric history. And what you have here is just kind of an illustration of a really standard, what we call a risk prediction score, which you can enter there online. You do the calculations yourself, you enter your risk factors, and it tells you what your risk of cardiovascular, predicted risk of cardiovascular disease is in the next 10 years. And on the red side, we've just added hypertensive disorders of pregnancy. And really, we're asking, does this help us improve that prediction? And unfortunately, the answer is not really. And there are multiple studies that basically show and have done this and looked at this in different populations. And they show actually knowing, if you know a woman's cardiovascular risk factor, and then you add in information about her obstetric health, her health during pregnancy, it doesn't change her predicted cardiovascular risk score very much. And these figures, which I won't go into much detail because of time, are figures that, again, we put together. We calculated that risk, that predicted risk of cardiovascular disease in the next 10 years in that Norwegian population. And as you can see, they're very similar, whether we, do or don't, if a woman does or doesn't have small for gestational age baby, pre-eclampsia, preterm delivery, suggesting that targeting interventions in these women in particular isn't going to change much. So her risk doesn't change, and therefore there is very little rationale to say we should be looking at these women more intensely to see if they kind of cross thresholds into treatment, say with antihypertensives or with statins earlier in life, or is there any benefit? Can we use this somehow in delivering screening, monitoring, interventions that target these subgroups of women? And the answer really is not so much at this point. So where does this leave us in this kind of research area? And to me, this becomes about healthcare delivery. And in the States, they're very big about talking about the fourth trimester. So that period of 3 months or so after a woman has delivered, and that's kind of what this figure is denoting. And it becomes about communication between, and this is again an American term, OBGYN. It's basically obstetrics. So the doctors who might look after a woman whilst she's pregnant, deliver the baby, and then PCP is primary care physician. So for us, it would be like a GP. And it's about having that communication, because we know that a woman who has had preeclampsia is at increased risk, but that information has to be recorded on their medical records. The doctor has to know about it. So there's a communication thing here. Plus, there's this postnatal checkup that women are supposed to have at 6 to 8 weeks postnatally. And we know that only half of them do. And actually, if you have preeclampsia, it's really important that your blood pressure is checked after pregnancy, and that you know that it's normalized, and that you know that you're done with that and can maybe continue, but it's important to establish that. And those 6 to 8 weeks checks, postpartum checks for women, it's really actually quite worrying that only half of the women in the UK have those checks. And I think that is me done. So I haven't done too badly, actually, with keeping up with time, Marcus. I'm just 5 minutes over. So and yeah, I've done a whistle stop tour. I hope that wasn't too fast and I haven't loaded it too much. But if there are any questions or anything you want me to kind of go back to, I'm really happy to take questions.
Abby, that was absolutely fantastic. Thank you very much. What a romp through what we know and what we're hoping to find out. And I know I am certainly going to be replaying this when it goes up on onto our YouTube channel in the next few days and onto the Poppy Study pages to go through everything. But we've got a couple of people with their hands up. Louisa had a hand up, but taking it down. And Ewa had her hand up. So do either of you two want to get started?
Oh, no, I was just applauding. It wasn't the hand up, but yes, thank you very much. That was really interesting. I don't have questions at the moment.
Okay. Have we got any questions from anybody?
Jane, go for it.
Hi, I don't know if you can hear me.
Yep,
Yeah.
loud and clear.
I just had a question about how far preconception, I mean, I know it's difficult to tell, but is there a limit in terms of how when you're kind of looking at preconception to conception and pregnancy, the time between? Do you want
No, that's a really good question. So I guess the way so you saw the data, so the Norwegian data goes, so the women become eligible to participate in the study at 20. So we would have data from around there. And in CPRD, it can be any age, but there's very little reason. You think about routine care, a teenager might have their blood pressure measured actually when they might want to start taking contraception. So a GP might measure blood pressure at that point. But that's what I mean about the data being messy. And also, what another bit of information that's important here is that we know that these cardiovascular risk factors, and I'm sure it makes total sense intuitively, that they track over time. So, people very, not that it doesn't happen, but on average, if you are overweight, you might be overweight for a long time. Your blood pressure unlikely suddenly jumps, so your blood pressure at 10 predicts your blood pressure at 12, predicts your blood pressure at 14, at 60, and so on and so forth. So I guess it depends what you're asking is like, is there an ideal time at which to measure these things might be what you're interested in, or when should we be measuring them because they might become informative? The later, the better, because you're older and therefore, anything that's later will be more predictive of your later life outcomes than early ones, than early measures. But I think that's the best answer I can give.
Okay, so long as they're over 20, and then it can be any time, they then can be years, yeah, from preconception to conception, and then pregnancy, and then
Yeah,
and the longer the better, because I guess you can get more data between that
exactly.
time. Yeah.
And for Poppy, of course, for our study, we are limiting that because we don't have the time or the money to hang around waiting for 10 years for women to become pregnant to then measure stuff. So there are logistics involved as well.
Thanks. Great question, Jane. Thank you. Carmel, you've got your hand up.
Yeah, thanks very much, Abby. Lovely to hear you speak on this topic. So, I mean, it's really interesting, isn't it, that we've got all this really robust data linking adverse pregnancy outcomes and future risk, yet adding that information into standard risk score calculators is effectively meaningless, or almost meaningless, is what you're saying. So how do you marry up those two things?
That's also a really, really good question. So I will caveat that and say one of the studies found that having a preterm delivery, of all of the adverse pregnancy outcomes, preterm maybe adds a bit of information. And I think that this comes back in some ways, that result is not surprising to me. One is that it comes back to what's causing the adverse pregnancy outcomes and causing the cardiovascular disease. So if it's kind of this underlying cardiovascular health, that we are capturing in a risk score anyway, adding on top of that information about preterm delivery or preeclampsia or whatever, you're kind of capturing the same thing. And so it doesn't add any new information. And the other aspect is that overall in a population, whilst these are devastating events, not many women have them, like overall in a percentage. And so it's actually adding very little information on very few women out of a population in total. So I think it's a combination of those two things.
Great, thank you. Louisa, did you have a question?
So applauding, like ever, actually. Thank you, Abigail. That was really great.
Thank you.
Okay. So I should just say there's quite a few people from the Poppy study online. So it's not just Ever and me, but there's various people dotted around, which is really nice to see as well. I mean, I guess the other thing would be, about this whole follow-up of women and the very last information you showed at the end of your talk, Abby. It's given what we've heard today, it's really worrying, concerning in a way that follow-up of women is so poor, and there must be so many reasons for that, but it's almost like that's a whole other piece of work that needs to be addressed or undertaken to try and redress that.
Absolutely. I completely agree. And in some ways, this is where my journey might end, because I've studied these questions, produced what I think is good evidence, tried to answer these questions, and then it becomes a kind of health services delivery, policy, healthcare question, which is super important because we can know these things, but if nobody ever does anything about them, they're really unhelpful. But it's kind of handing over in some ways this evidence to people who work in that field, so who deliver care, who write policy documents, and for them to take up that challenge and to try and improve that. And in fact, it can be done. We know that it can be done. So I know there are, in Canada, for example, there are specific clinics for postnatal health delivery in women who have experienced an adverse pregnancy outcome. So where there's a will, there's a way. It does not mean that having that information is meaningless. It actually means that we now have to take it and do something about it. And even and I mean, that's why we're here today, right? To educate, to tell women, to spread awareness. That's why we're doing the Poppy study, so that we can get the best evidence possible and then start to think about where is the right time in a woman's life course to offer advice, intervention, support, so that that, because it's not deterministic. You don't have to have heart disease and stroke if we can do something about it. And that's the beauty of these adverse pregnancy outcomes, is that they manifest when women are young, when they are in their reproductive years, when they're having kids, when things can be changed, and even little changes can have really, really big effects over a period of 30 years. Until they're in their 60s and 70s, and actually we start seeing these heart disease and stroke outcomes.
Can I ask another? I'm sorry, I don't mean to be dominating the questions, but Marcus, can I ask you a question? Oh, we've lost.
Sorry, yes, of course.
So is that on Action on Preeclampsia's agenda then, that sort of lobbying government or lobbying around better follow-up of women who've experienced preeclampsia, or is that not something that you've kind of strayed into in your work?
I mean, lobbying is something that's very important to us at the moment, particularly with placental growth factor test implementation, where we've achieved great success in England. But only this afternoon, I've had an email from the Office of the First Minister of Scotland saying that they're listening to our lobbying at long last. So hopefully we can get testing in Scotland, and this is a big area for us at the moment. Is getting that testing during pregnancy absolutely right, and where Poppy comes in before that and after pregnancy is so important to the work that we want to do, because we know that the incidence of women dying and babies dying from preeclampsia is historically low, no room for complacency. And we've seen over the last few years the numbers rising in the Embrace reports. So we're still very much focused on the day job of dealing with women with preeclampsia, but as far as I'm concerned, that includes all hypertensive disorders of pregnancy, and it has to include the follow-up and dealing with women going into the future as well. And we have this wonderful opportunity in pregnancy that we're not really taking full advantage of seeing a microcosm of the woman's future health, and we need to get to the bottom of what's going on in women's health and how we can use that information, how we can use the data that we're getting routinely in pregnancy, and use that to improve public health. And that is very much one of the factors that's driving me. So yes, Kamal, this is right at the centre of where we're thinking at the moment. Is that okay? Jane, you've got your hand up.
Hello, sorry. I was wondering then, with the patients that take aspirin to prevent preeclampsia, they'd obviously have the pre-existing risk. Is there any way that you could use that, exploit that to see any further information about the risk between preeclampsia and CVD risk later on?
How do you mean, Jane? I'm not like.
Because you know, the patients with that, I'm trying to think this through at the same time.
Yeah.
With this, so I work with Marcus on as a PPI person on the Starship study, where we identify people that are at high risk of preeclampsia and give them aspirin to reduce their risk of developing it in the end. So they'd obviously still have the pre-existing risk of preeclampsia later on, but the aspirin's done something to stop them from having that in the end. And I just wondered, is there anything there that would give you some clues about how that risk is being like?
Yeah, I think I understand what you're saying. So you're saying that by comparing, I guess this comes back to the effectiveness or the efficacy of aspirin, right? So you're kind of comparing women who are so at high risk, who are prescribed aspirin versus those, except that. I mean, I don't know the historical trials. Carmel might know more than me about the effectiveness, but now you would never prevent a woman from having preeclampsia, of not giving her. Now that we know that it works, it would be unethical to withhold that treatment from a woman who you identified as being eligible for that treatment because of, that risk that she has. So that's one comparison that you might be interested in, but actually you couldn't do because it would be unethical to withhold that what we know is effective treatment. But that's been established. There's no need for that study. What it tells us mechanistically, I think, and that might be another aspect of kind of your thinking. I'm just thinking out loud with you, really. These adverse pregnancy outcomes, I think, are so complicated, and like many other human diseases and conditions, they're really complex. There's no kind of one cause. Some conditions, there's one cause, you get the disease. If you don't have that, you don't. But like most conditions, It is kind of a really complicated interplay between mom and how and her, and don't forget it's even more complicated than most diseases because it involves two people. It's mom and baby, and the interaction, or at least there's some evidence to suggest, that there's an immune response. So it might be that that particular combination of mom's genetics and fetus's genetics causes an immune response. There's so many reasons, and the etiology or the causes of these conditions is so complicated that it's piecing together those causes to kind of understand what's going on. But I'm not sure that the aspirin piece, I'm struggling to see a bit, to kind of in my epidemiological mind of trying to think of a study design that we could use to harness that, is how that might help. And but maybe somebody else has ideas about how we could leverage that.
Yeah, I'm not sure we can leverage it, Abby. I think it's something we'll need to take into consideration in
Poppy.
So we can't escape from it in the Poppy study. I suppose in a purely unethical way, you wouldn't intervene in women. You just sit back and see what happens. But obviously, we don't do that clinically. If we know a woman's at risk, she will be given aspirin to take. So I guess we need to just take that into account in our analyses. And I suppose the other thing I'd also say is don't forget about the father's genes as well. So that immune response, as we've all been listening to in Cambridge, as well as that, it's all three actually. The sort of immune response to the fathers.
It's the baby. Once the baby's there, the dad's
the dad's not necessary.
Okay. I'm totally kidding, but yes, you're absolutely right. I will say, Jane, that in Poppy we're recruiting nulliparous women, so women who have not had pregnancies before, which is one of the highest risk factors, or the leading risk factors in pregnancy number 2 is if you've had preeclampsia in pregnancy number 1. And so we will not have women who are going into pregnancy number 2. It will only be women in their first pregnancy for very much that same reason of keeping things as controlled, neat, and simple as possible.
Thank you very much. We've got 5 more minutes. We need to wrap this up at 7 o'clock, but I can see Rebecca's got a hand up. So I'll fire over to you, Rebecca.
Thanks, Marcus. Thank you. I just wanted to ask really how the Poppy study is going. I'm a research midwife. I'm really interested in it. I've got a particular interest in cardiovascular disease and pregnancy. And I just wondered how it's going with recruitment. Are you having any difficulties? Is it on target? And all of those things. Thank you.
Well, that's the most perfect question, because I was going to finish by thanking Abby so much for what she said and ask Ewa to give us a quick update on the Poppy study. So thank you very much, and I'll hand over to Ewa.
I think maybe Carmel would be the good person to do it. Okay.
Oh, you can do
should
it.
I do it? Okay, so we have recruited about 350 participants right now. So we are looking to recruit 3,500. So obviously we've got 10 times more to go, and we have 3 sites open, but still looking to open 4 more, and soon we'll be opening 3 sites. So in terms of recruitment, we have to recruit a lot every month, so it's a challenging challenging number of people to recruit, but I think it's going quite good. We are recruiting from communities. We are recruiting through engagement with the communities through posters and also on social media. So the more we can spread the word about Poppy, it's extremely helpful for us, because that's how we need to invite people to the study. Carmel, you want to add something?
Yeah, I can add something. Rebecca, I'm not sure whether we've actually been in contact anyway in the past, I suspect, and we will be reconnecting with you, because actually St. George's, and I think they're on your patch, if I'm not mistaken, St. George's are about to come online. So it's taken a long time to get site agreements, etc., sorted, but they are just about ready to start. And I understand that they fall under your CRN patch. So we will definitely be in touch.
Oh, yeah.
So we look forward to working with you, hopefully.
Lovely. Thank you. Likewise.
Great.
Okay, have we got any final questions, or is now the time to wrap up our hour? I'm not seeing hands raised. I'm not seeing any particular rush. So, Ewa, thank you for organising this along with the team at the Poppy trial. And Abby, thank you so much for what a fantastic, fascinating insight and a wonderful hour that we've really enjoyed. So thank you all very much. And please do keep in touch with the trial. Please keep in touch with Action on Pre-eclampsia. Anything we can do, just please let us know. We are here to work alongside you, work with you, and we need some more recruits for this trial. So please do help us with that. And but I would just like to say thank you all very much.
And thank you, Marcus, for helping us so much and supporting. Thank you, Abby, for a great talk.
Pleasure.
Thank you,
Bye, everyone.
Thank you. Thanks, Abby. Thanks, Marcus.
Bye.
Bye. Bye.